Welcome, everybody. We are starting the event in 1 minute's time. We're just giving time for people to come in. Thank you so much for coming. And some of you might be here for the first time in this series, but it's a little bit different. And because you might notice, I know I swing my arms around a lot, so you probably don't notice, there's two organizations. We have SenzMate, and I'm going to be bringing on Miller, founder, one of the founders of SenzMate, and the UKDHC, and we are working together to produce this event. This is a new partnership, and I won't belabor the point, but why are we doing this? And this question, leadership, I'm going to tell you just from my point of view, because Angus reached out to me a couple of months ago. 2023, when I'm in events, I'm talking about AI and healthcare, the leadership doesn't come up. 2024 doesn't come up. And that changed within the past 6 months. And people are speaking about it all the time. So when Angus tapped me on the shoulder, I was very eager to talk to him. I'm going to bring him on. Let's see. There you are. Hello.
Hi, Jose. It's wonderful to be here, and I'm very grateful for you partnering with us. UKDHC is a UK-based organization. You have an international audience, and this is an opportunity for us to explain to everybody what UKDHC is doing. So I'll save that for later and hand back to you.
Miller.
Hello, everyone. Good evening, good morning. So this is an amazing opportunity because you might saw us, SenzMate. We're doing it for 2 years along with Jose. And this time it's very special. More hands will be very stronger. And this webinar from tech event to it's become a community event. So we thought it might be better to have much more support globally. And now we are covering not only tech, the health and people also, human aspect of it. So we thought with Professor Angus and team, this is an amazing synergy with the UKDHC. And I'm honored to be here and welcome everyone to the session. Hope we have a good session going ahead.
And thanks, Miller. We're going to bring Angus and Miller back. So we'll bring now. We have two audiences here. We have one here in Zoom, and another one on LinkedIn Live. If you're on LinkedIn Live, put questions. Feel free to put your comments in the chat, and everyone's welcome. Just so you know, at the 1 hour mark, the LinkedIn Live kind of will end, but we will continue here on Zoom. And that is going to be, we're going to paste the Zoom link into the chat on the LinkedIn event page. So you just click on the Zoom link and you can join us here in Zoom. Because we're not streaming the after party. Maybe the after party is not a really good term, actually. But we're not streaming that to LinkedIn Live. Now, Sonia, welcome.
Hi, thanks for having me. There we go.
Sonia, I wonder if you can do you mind introducing yourself to the audience? Because I mean, we've spoken, but it was quite brief.
Yeah, so I'm a cyber psychologist in the UK and a digital policy advisor. And I work on predominantly what sustained AI use does to human cognition, professional identity and judgment, and what organizations and individuals can do about that.
Well, that came up in our webinar yesterday. But it was fascinating. I wondered, if you could start us off. There's been the NHS has been through major digital transformations, and EPRs, registering, digital referrals, and I think when I started doing health AI events, people were just saying, "Oh, it's just a new wave of technology." Is it GDPR compliant? Is the data secure? Okay, that's fine. It's just another technology. We've been through this before.
Yeah.
Is that true?
No, it's not, in short. And I think it's the instinct in the NHS to treat each new technology as a variation on the last one is the fallback position. But with generative AI, that instinct, I think, misleads us a little bit. So if we took the example of, electronic patient records as a tool, that holds information. It records, it retrieves, and it structures. And clinicians learn it, and they might grumble about it, and eventually they'll interrogate it into their workflow. But the electronic patient record as a tool, it doesn't change what's happening in their head when they make clinical decisions. It supports the work. It doesn't participate in it. And generative AI is a different category of thing. It produces outputs that look like judgment, summaries, recommendations, draft letters, suggested actions. So the clinician isn't necessarily using a tool that holds information. They're working alongside something that's doing what their brain is also trying to do. So that changes the cognitive relationship, and it changes what good adoption looks like. So I don't think we're no longer asking, can people use this? It's more about asking around kind of what happens to their thinking over months and years of using it. And that reasoning is important for leadership, because that is the framework that we've used for previous rollouts, the training, the change management, the post-implementation feedback. They were all built for tools that support work. But what they don't pick up is on what happens when the tool participates in it. So we end up declaring success on adoption metrics while actually missing the thing that actually determines whether this works long term. And I think which is whether clinicians stay in the lead of their own judgment. So for me, that's the shift. It's not that AI is more dangerous or it's harder to deploy. It's that it asks a different question of all of us, and we're still answering the old one.
I'm not asking you to comment. I'm just going to have my little take. And I've seen a lot of people in AI say this. It's not really intelligent, but it has agency. It's something that has agency without consciousness and can behave. And that's hard for people to wrap their head around. And so I'm not asking you to comment on that, but so how do people start to get their heads around it?
That's a good question. I think we have to look at kind of what it is we're asking clinicians and the workforce to do. So whether that's the non-clinical workforce and the clinical workforce, what it is that we're asking them to do with AI. What's the purpose of it? What's the solution that the problem that we're trying to solve here? Because AI is deemed as this silver bullet that's going to solve everyone's problems. And there's a lot of talk about productivity and efficiency in the system. But I always ask kind of, for what end are we being efficient and productivity? Because there's lots of conversations around, something that used to take me 4 hours is now taking 2 hours. But what are you doing with those 2 hours that you've saved? Because anyone that I've spoke to they're not having breaks in those 2 hours. They're not clocking off 2 hours earlier. So what is it that they're doing in those 2 hours? And predominantly it's more work. And I think that's the bit that we need to be mindful of when we do these rollouts. And when we talk about adoption, what does that look like? Because it's not that the work is disappearing and it's not that the work is changing. It's our roles around that is changing. And how do we manage that as humans?
You know what? I interviewed somebody a few months ago. She was in procurement and policy. And she says, who gets to decide what's a lower value task and what effect that has on people? Yeah. And traditionally, and what is that lower value task mean for somebody? And I've heard a lot of people, for instance, a lot of people, I need that lower value task. I'm actually doing something.
Yeah.
That's actually where I recover from. And now you've automated away all the bits of my job where I could regulate my nervous system. And I'm now in this intense state the entire time. And I'm like, it's like being in an you've taken away all the relaxing bits.
Yeah. I think there's a tendency to remove the friction from all processes and all kind of process that we go through. But actually the friction is where the thinking happens. So that's where we need that time to kind of cognitively upload all of our own thoughts and our own judgment, our own decision-making processes. Whereas if we're handing that over to AI, say, for example, with the ambient voice technology, it is, a great system, a great tool, has many, many benefits if it's used appropriately. When you are streamlining everything and you don't stop and think about the behavior that you're doing and adding your own judgment in there, what is it that you've done? You've handed over your cognitive thought process to AI.
How is this being, how advanced is this thinking? I mean, was people aware that it's a problem? They're aware that it's an issue.
Mm-hmm.
And you've actually articulated it very well in a way that I've not heard before. But where do we go from there?
So I think there is a behavioral gap in our current governance frameworks. The most AI assurance frameworks measure the technical performance, which of course is important, and that deployment process, and user feedback to a certain degree. But none of them are measuring the judgment erosion, that automation bias, or those cognitive habits that determine whether that human in the loop, which is not a phrase I'm a fan of, but because it's a never-ending, always-on loop, but whether they're actually leading or being merely present. So I think that's one of the things that we can see in the US that is starting to be retrofitted now. So with the UK, we've got a really good opportunity now to get on top of this before AI starts to be the norm and rolled out. I mean, of course, the variation of what technology deployment looks like across the UK is huge. You've got some organizations talking about agentic AI programs being adopted. You've got some teams that can't change the personalization in their outlook. There's a huge gap here. And I think what we have to do is have that conversation that turns the governance and the regulation or safety into kind of what this means from the workforce perspective, and that kind of including psychological safety as a precondition for that.
Thank you so much, Sonia.
Thank
you. You got us off to a great start.
So follow that now, guys.
I'm going to bring on our next speaker, Sonia. But are you okay to come back in about 30 minutes?
Yeah.
Thank you so much. And David, I've never laughed so hard as I did in the rehearsal for this event. And I couldn't actually listen to David's story because I was laughing so hard. But David is here to talk to us, by the way, about leadership and developing leadership. But before I do that, I wonder if you can introduce yourself.
Yeah, thanks very much, Jose. Really great to be here and lovely to see all the different nationalities or from where people are from. That's wonderful. Very quickly, my background originally started in the UK, went to Australia in 1982 to play sport. I was a sports fanatic and ended up getting into healthcare early on via private health insurance. I got under the bonnet of that. Then I went into administration with regards primary care. I ended up chief executive of the Royal College of GPs for Australia. I set up the accreditation of primary care in Australia, and I've been an advisor to the European Commission and the WHO on systems improvement in some of the low middle income countries around the world. I'm now a director and acting chief executive of UKDHC. So that's a very quick snapshot of my background. If I may, the healthcare, AI leadership and human systems, you made me think about it. I've always had a very simple analogy with regards leadership. And there's a really simple English word that if you change the letter in front of it, it gives it a whole different meaning. Okay, if you put the word authority and then you put in front of it in authority, in other words, the leader is in authority, on his shoulders he's got a couple of pips, or he's the designated CIO or the CEO, he's in authority. If you change the in, if you change the letter I to an A, they're an authority on a subject, the content, and so on. So it's that subtle difference. When you get those two together, that starts to, and you add the charisma and character of that person to be the leader in that area, that's when people follow. So it's a very simple analogy that I followed because I've seen many, many people in healthcare with the pips on their shoulders and they haven't got a clue. I've seen many, many people with the knowledge who haven't got the opportunity to share that knowledge and lead other people. And it's putting the two together to drive change. Now, I'm all about systems change and systems improvement. And that's been my background for 30 odd years in healthcare, working in different countries, the Middle East for 4 years with different governments and so on. So it's all about systems improvement. We're now talking about AI, which has exploded and it's continuing to explode. What are the guardrails? What are the people we need to listen to, absorb, take on board, and so on, before we get on the horse and ride off in all directions? That's what I'm worried about. People leave meetings, they get on the horse, and they ride everywhere. So from a leadership perspective, it's all about absorbing the knowledge, taking it on board, taking the good parts, and then analyzing and taking issues forward with people. I've got a very simple slide that I'd like to share, if it's okay, Jose,
please do.
Participants. And I've used this on many occasions. Angus, you've seen this before, but I've modified it slightly because of the impact of AI. And I've shared this with many different ministers of health in different countries to get them to understand that they have to sit in the helicopter looking down on the system that they oversee, because many of them get embroiled on the front page of the newspapers on a Monday morning. Because if there's nothing to talk about major, health ends up on the front page. Waiting list, corridor care, and so on. So I'll just share this, if I may. Okay, I want
it's kind of light. It's kind of white.
It's supposed to be at the moment.
Oh,
I'm going to fill it up. I want everybody who's online to be in the helicopter looking down on this. Okay, and it doesn't matter where you are. And I saw somebody from Vietnam and Washington and so on. Take a look at your own health system and where you sit. When you look at complexity and volume, let's break it very simply down into 3 areas. If you've got a headache, you know what to do. You go and see the pharmacy and so on, and you pick up a whatever. Primary care, you might go to a GP or a general physician to have a chat. Secondary care, that's when you're in hospital. That's the volume under that care. The more volume at this end, primary care, tertiary care. 95% of all care is outside of hospital, but a lot more of the money is spent in this area. These are the problems. Now, when we get back to AI, and I'll get there in a moment, let's build this up, because I want you to place yourself somewhere under that curve, whether you're a clinician, whether you're a patient, whether you're an administrator, you're in there somewhere. We're all in there. In the UK, there's 68 million in there. These are the pressure spots. AI can make a huge difference in those areas, and we'll get to that in a moment. Now, we need to get the leaders to take cognizance of these areas big time, because this is what can change the way healthcare is delivered. And we need the leaders around the world to actually pick up on this. This curve is expanding. Comorbidities, aging population, and so on. That's growing. The dollars are being spent. Everybody's struggling with this. The aging population. In the UK, we've got the 10-year plan. Moving the care from hospitals to the communities? Have we really thought about how that's being done? Analog to digital. Yes, big push. Many, many countries have spent fortunes on this already. EPRs, etc. A fortune. Has it been spent wisely? I'll leave that for somebody else to raise their hand on that one. And obviously moving from sickness prevention. All very good, all very interesting, sort of key 3 areas. The key things is to move these 2 vertical lines to the right. AI can do this. How do you move that line and this line to the right? Those 2 lines there. In other words, how can we increase self-care? How can we improve the appointments to get into a GP in the UK is pretty tough. And obviously this area is all about discharge planning and admission planning. We've now got remote patient monitoring. I know AI is making a big move into that area. UKDHC has got a small conference at the Royal College of Physicians in London on the 22nd of June, where we'll be talking about some of those issues, how to use AI with regard to remote patient monitoring to improve the care and reduce the pressures here and here. It's my belief that if we're going to work on this 10-year plan, the community care is going to be improved absolutely considerably, big time. Communities have to take more ownership. How does that occur? Well, it needs strong governance at a local level. And trust is paramount. I know Professor Angus and myself, we've had conversations, he's been to meetings. We're trying to join up social care and healthcare is very, very difficult because of the silos that they work in. This is where AI has a chance of major impacts, but it also has challenges. In this area, it's all about patient education. You've got so many people going, so many patients now going to clinicians loaded with information in their pockets about what condition they have. That can cause anxiety. It increases their education and knowledge about it. And as someone said to me recently, he said, knowledge is free nowadays. No longer is it just a Google search. You can use any of the AI assistants to help. Access to knowledge is improving exponentially. But this is where the improvements are going to be made for AI. It's workflows across, within, and between sectors, not just in a hospital. I'll say that again. It's across, within, and between sectors. This is where these 2 red spots, I believe, are going to be the crucial areas to focus on in the next few years to improve healthcare. I'm happy, Jose, I'm happy to leave it on that with regards this short slide presentation, but I want everybody to take their big picture analysis of this, looking down on your own health system, wherever you are. I've done some work in Cambodia, so I know that area. So the person talking with regards Asia and the Pacific region, I've worked in a couple of the private hospitals over there. So it's the same model for most countries. I'll stop sharing.
Thanks, David. Before you go, I just want to make a comment. And I just did a personal observation. I read people, and I visit my uncle in a care home twice a week, and I chat with the people in the office. Oh, what do you do? You know, I produce webinars on health AI, and he's like calling his coworkers to come over. I felt like Mick Jagger, and I never feel like Mick Jagger. No one's going, you know what I mean? If I tell people I produce webinars on health AI, people aren't calling their friends over to come like interact with me, but there they did. So to me, that means something. That's not, it feels different. There's an appetite. And, but that I don't see in conversations I've had over the past 2 or 3 years. But maybe that's a coincidence. But
No, I used to visit my mum in she was in a nursing home in Plymouth, in Devon, in England. And I was in Australia working. I used to come over twice a year to visit her. And I used to go into the nursing home, and I ended up analysing her medical record. I ended up walking down to her general practice, knocking on the door, well, almost kicking down the door, because I wasn't happy with the care plan that she was under, and realising, and once I'd done the research, I realised that she was hallucinating because of some of the drugs she was taking.
Oh, wow.
And this was 15 years ago, and now I look back on that and I think, well, I should have been able to monitor her care wherever I was in the world.
I think when you say monitor, and it's very interesting because I have a conversation with my aunt about this. She hates her smartphone, but I've enrolled for a pilot for an app, and she's, oh, AI app on my phone. Yeah, but I'm going to be the one talking to. I'm going to be in dialogue with it. Oh, it's another way for me to be connected with you, and then it's a different conversation when the AI is an intermediary facilitating communication with somebody they trust, as opposed to, like, say, a big tech company. I noticed that was an inflection point, and because I've never seen my aunt interested in an app on her smartphone before. David, I'm going to bring you back on in about 20 minutes.
Sure. Thank you.
Thank you. Miller.
Hi, Jose. It's really impressed today. The session was amazing. And thank you so much, David, for the complete presentation. I took a screenshot. I think that's a real information we have to consider. So David touched on a point, Jose, that the tech, it's not something focused on one segment. It's supposed to onboard every single stakeholders in every single ecosystem. It need to be expand. At the same time, it need to interact with each and every component. So basically, we call this the AGI. Now we all talk about the generative AI. The next version is agentic AI. So we talk tech a lot in the past, but it's not humanized yet. So that's the biggest complaint when it comes to medical ecosystem. Tech is not humanized yet. It's not empathize towards the patient. It make decisions rational. It's more numbers and statistic. Where the probability goes, it goes with it. So that's what the future is all about. We call it AGI, artificial general intelligence. So we consider many information, much as possible data. Already it's bombarding with data, but in future, it's make more information more than data. It consider different aspect and make a cumulative decision, cumulative activity to complete certain things. So now we are entering to a healthcare. It's no longer just hospitals and doctors and medical devices, has exactly what David mentioned. So it's become more of a living, intelligent ecosystem. So a human system powered by AI. That's the future. So we exactly running a conventional lifestyle, but it's just backed with AI. So you don't even feel that we are using AI. It's just a norm. Taking a bus and going to a place 100 years back, it's not the case, right? So you have to walk, or you have to have a cart, horse cart, or you're jumping into an animal's back. So that's not the case. It's going to be a new normal, just like post-COVID context. So we're moving towards a human system that's powered by AI. So today, healthcare system data is everywhere. We have more than enough data from wearable devices, diagnosis environment, through sensors, nutrition, behavior, genetic data, and real-time patient monitoring. So there are so much of information and data is available. We generate massive volume of information every single second, never been before in this scale. But the real challenge is not collecting data. It's not only in the Western world, the developed nations, it's also, I'm coming from the global South, the access for information is already there. And for the first time, human being, every single human in the world have access for a high performance computer with a simple interface. So the changes happens parallelly for the both world. So that's the most important part. So the challenge is transforming the fragmented data into human intelligence, meaningful human intelligence. So that's where the world is moving towards. That's where the health AI leadership comes into play. So the future belongs to organizations that orchestrate AI, not as a standalone tool. So if you consider that as a tool, it's just another tool. You have different machineries and you're just replacing that machinery. To accept this is like an ecosystem, it's a new normal. It won't be a standalone tool, but it's a decision-making layer across the entire healthcare journey. So that's how it's going to be changed. So that's how the entire world of AI changing, as I mentioned, from generative AI to AGI, artificial general intelligence. So imagine a system that predict diseases risk before symptoms appear, because you understand the environment, the stress, the lifestyle patterns, nutrition, the biological signals together. It's a real-time information. So it's predict before things happen. So you don't even feel I'm going through a medical treatment, I'm going through a scanner, I'm going through an MRI to detect I have a disease. This is already predicting because of your behavior, how you are living your life in the day-to-day environment. So healthcare framework that shift from reactive medicine to predictive and preventive intelligence. So this is where the science, it's not a science fiction anymore. It's already happening, but it's not normalized throughout the world. But there's a critical point at AI alone are not a solution. So that's we have to accept as engineers or in the tech ecosystem. The real value emerge when AI amplifies human systems like doctors, caregivers, researchers, public health, or even patient themselves. We must move beyond isolated applications, start building a connected ecosystem. So that's what the takeaway of my conversation. It's not like an isolated solution, a silver bullet for everything. AI is not that. So we are creating an ecosystem which intelligent enough. It's go with precision medicine and digital therapeutic and AI assistant diagnosis. Any application we build, they will design trust, interoperability, how it's going to be communicate with different frameworks, and it include ethics and a scalable human-centered intelligence. So that's what it makes more special going towards. And the final question is no longer whether AI can transform healthcare. The final question is all about who will lead a transformation responsibly. So the future of AI, which cannot be a silver bullet, it cannot be a standalone tool. It definitely include human aspect and the human ethics and human community, and consider the entire ecosystem and bring a general environment. You don't even feel you're using tech. It won't be a transformation. It's a complete a reality change in terms of how we're going to use this tool. So I'm really excited towards that, and I'm really happy that David mentioned about 90% of medicine is not happening in the hospital. So that's proof this need an ecosystem which is not beyond, it's happening in the hospital, it happens beyond the hospital. So I'm very hopeful for that, and looking forward for a connected world, and most importantly, it must be a deeply human technology. So yeah, over to you, Jose.
You remind me of, there was a webinar we did a couple months ago. I think you didn't attend because you were flying. And what you just said there really reminded me, and this is, and a lot of people are talking about this. I'll just, somebody goes for an ophthalmology scan. So they have the retina. And so they go in for the scan for a specific purpose. But then while we've got you there, we're going to run this through some algorithms, and we can detect neurodegenerative conditions from your retina.
Yeah.
And so it's kind of like reimagining, and it's not diagnosing. It's just, oh, you're at risk of Alzheimer's. You've got the early stage, you might. And then we're going to refer it to a person. So all of a sudden you go in for an ophthalmology scan, and then you might get referred to a neurologist. And this is, and that's not that specific example. It's not just about that specific example, but that's starting to happen. Sorry about that. That really comes through. I'm going to send you the clip, actually. I don't know if you've seen it yet. But it was like, but the thing is, and you know what, you can point out the possibilities, how's the imagination? Like, because you have the technology that say this is possible, but then there's the human system. People always say the human system, like the people working in those, oh, by the way, the rectin is part of the nervous system, the central nervous system, and connecting all those dots and then reimagining. How do you collaborate to bridge that gap between what is technologically possible and what healthcare leadership imagines? I mean, sorry, maybe that's too clumsy a question for it.
No, I get partially understand that question. So it's only possible because at the moment AI works like a tool in the healthcare ecosystem. That's where it mostly end up in a prototype. It's not. People use AI or whatever the digital technologies in terms of diagnosis and for the purpose of analysis. Still, it's not even in a perspective of considering directly towards the therapeutic application. There must be a human intervention or a doctor or a professional who's supposed to moderate in terms of applying it. So whatever the application we build, it happens on a silo. For that particular disease, for that particular use case, there will be an endpoint. It's not interconnected. The endpoint will be a human aspect to moderate. So the healthcare become more connected to make this kind of a general intelligence. Only it's all communicating each other. All the biomarkers around the world communicating to one point. So yes, the regulations and everything are basically standardizing the way it's supposed to work, but there must be a mechanism where the AI or the intelligence, forget about AI, the intelligence, general intelligence must learn from all this information in a central aspect. There must be a regulation bound, but only if it's, as you rightly mentioned, as our human body, a central neural system which is supposed to understand everything. Now it's all happening in silos. When it's happened through a central process, then you are connected to an ecosystem which may consider different aspects to give a therapeutic context. So you must have trust on technology. Everyone needs to trust, and the governments need to trust. Policies need to accept. So there's a long way to go, which is more theoretical. At the same time, it's more policy oriented. In terms of technology wise, it's done yesterday. So it's all about the ground scenario, how to implement and making something generalized. So I hope it will be moving forward. Countries like Singapore is taking the first step, bringing AI ministry in-house. So I think this is not far away.
Thank you, Miller. Can you stay for the after party?
Yeah, for the second half, for sure.
Angus. Sorry about that.
Hi, Jose.
Hello, Angus. Sorry.
I am delighted to be here, and listening to David's presentation was a real delight because it does highlight where we are going, what the problems are, and as you get older, and I am getting older, you become more dependent on the healthcare and social care systems. So I am beginning to care a lot about the healthcare and social care systems because you pick up diseases as you get older. You ideally want to manage them yourselves as much as possible, but you do occasionally need to call on hospital services. Now, my common sense is not as good as it was previously. As a consequence, that finger argued with a saw 7 weeks ago, and I was very dependent on hospital services to help me deal with a finger that I could not have dealt with myself at home. I also have other conditions, and I want our health service to be as good as possible, and I want our social care services to be as good as possible. And quite honestly, we are obstructing that at the moment because we are not thinking carefully and in a planned way about how to get better. When I was in hospital having my finger treated, I observed the medical staff and the dressing staff and the OTs who treated my finger for 5 minutes and then spent 10 minutes keying the information onto a keyboard to go into the electronic patient record. That was a complete waste of their time. And we are moving towards ambient voice technology, and it's important. Ambient voice technology, you talk. The computer picks up your voice, makes notes, and you are left to simply edit the notes. You really do have to use that technology to make our services better. It's really challenging. And David highlighted that a lot of people who are trying to move this forwards do not understand what the technology is. And they must come clean. They must realize they don't understand, and they must get people in post to help them understand. Now, I think it's important to recognize that AI is going to change our lives. And you can see here 2 types of dog. The one on your left is a guide dog for the blind. And that dog is a loving dog, looks after its master, keeps its master safe, and ensures the master goes along the correct paths and the correct road in order to remain safe. However, there are other kind of dogs, like the Rottweiler on the right. It will bite you. It will damage you. It will cause you harm. And AI can be either of those. We want to culture AI to be a guide dog, to help us. I want AI to help me be independent at home, look after myself, and not bother the medical and social care services. I want to be independent, and I want AI to help me. However, I am very aware that AI is potentially harmful, and I want somebody to protect me from the harmful side of AI. I don't want somebody to remove AI from me. I want to use AI. I want to use it safely. And I see now in the UK too many people trying to prevent AI from being introduced because they perceive it's unsafe. We have to recognize that there is always a balance of risks. There are risks to using AI, but there are also risks that you will undergo if you don't use AI. And I do think that a number of senior people within our NHS haven't quite grasped the importance of moving AI into our health services quickly. And I would love to see more AI being introduced into social care. I think it could transform social care unbelievably. But it's got to be the frontline workers who are doing it. And I have spoken to social care leads who have decided they're going to set up their own AI division to help the social care workers use AI. I don't want that. I want them to teach the frontline workers how to use AI. I don't want technicians to develop schemes that they believe might work with the frontline workers. So I think we need to change our image of what is going on. We need to ensure that we use AI to benefit ourselves and our community, and it can make a huge difference. When COVID broke, I learned you can do an awful lot with very few facilities, in the same way that you can do an awful lot with AI facilities. During COVID, I was at home. I was isolated because I'm older than most of you. And I worked with a guy called Suhail Shukdai, who is a Pakistani surgeon. He set up a program covering a third of Pakistan on advising the population about COVID and whether they needed to be in hospital. And he set up COVID advice centres. And the only way he could make it work is not by using high-powered technology, because their broadband is low speed, but simply using their mobile phones, going on to an advisor and getting advice for the symptoms. AI could have done it better, but AI wasn't up to it at that time. I would like to drive forwards AI in the UK with David, move that line between self-care and secondary care to the right, so that we are all looking after ourselves better. And I'm doing one thing that I would like a lot of other people to help us with. I am forming with a group of doctors and health advisors an organization called Undoctored Truth Alliance, the UTA. And the Undoctored Truth Alliance has been developed so that we can guide people about what on the internet, on the World Wide Web, is inaccurate and what can give you good guidance. Because that is what is needed now. We need to monitor what the public are being told, but we do need to use AI. And I would love now for Sonia to come in and tell me whether I was talking rubbish or whether she agreed with me.
What a throwdown, Angus. Gosh, there's so much in there, and I agree with your leash metaphor. The dog leash. So I think, and I've put a comment in there. I think there was also a question in the Q&A bit around, that links to patients arriving with more information, which is what David mentioned as well. So I'll take it 2 points if that's okay, Angus. So my first bit is around patients arriving more informed, I think, is a good thing. So, but the question, I think, is around what they're informed with. So, which is to your point about, the rubbish that's out there. So 2 years ago, it was symptom checkers and it was forums. And now it's the likes of TikTok, giving them confident, fluent, plausible sounding answers that may or may not be accurate. And so within that, I think the clinician's job has shifted significantly. So they're not just answering questions, they're navigating something that's pre-formed, a narrative that the patient is arriving with already, and they've already half committed to. So I think that's a different consultation skill that we haven't yet even named, let alone started to train for. So there's that element of it. And then I think in terms of how they come in and how you communicate, there's lots of elements around what's out there and how we mitigate that. So that I think we all know about misinformation and disinformation and how that is impacting. And, I won't get all nerdy and talk about, system beliefs and why people believe this nonsense and why they don't, and they come with those things. But I think there's also an element of NHS organizational responsibility for what they put out there into the ether and into the world, and how accessible that is for patients. Because, if you take the BBC, for example, they have their fact checker system, anything they put out there. In the NHS and within health and social care across the world, actually, there isn't that one element of actually this is the go-to one source of truth. There are multiple truths across the world, and lots of things can be true at the same time. And I think that's one of the things that we have to navigate from the patient and the public perspective, is that where do they go for that information? We shouldn't be going to TikTok as organizations just because that's where patients are. We should be pushing actually that the NHS, a central resource, or your local organization, is that one source of truth. And that's where I think we should predominantly be leading that. So I'm interested to see what the kind of the undoctored Truth Alliance comes up with, because that sounds like an incredible passion project, Angus.
It is a passion project. I must admit, having listened to you talk, I would love to see a nerdy Sonia, because a non-nerdy Sonia is quite exciting. But I can imagine a nerdy Sonia would be quite special.
Happy to get involved, would love to.
I wonder if David would like to come in and just give some comments, and then we'll go back to Jose.
There he is.
My apologies, I was on mute. No, I was just absorbing that conversation. It's, I read so much about Doctor in the Loop, but after analysing it, I want to make sure that doctors are not on the hook as well. It's all very well having, doctors, they still need to take responsibility for this, or clinicians and health professionals taking responsibility for decisions which are AI influenced. But we've got to be careful that AI can contribute to errors as well, and error minimization.
Sonia, you emphasised the importance of the NHS providing information for patients that patients could understand and they would trust the NHS. Unfortunately, the NHS did put out a publication recently which was supposed to include patients. I put it through a checker to see what age of patient could understand what they had published, and you had to be at least 30 and a university qualified person to understand what they put out in their published article. Yeah. So I think the NHS has a bit to learn. I did translate it for them. I sent it back to them, and I got the normal response: "Thank you for alerting us to this. We will look at it." And I've heard nothing else. So I think it's really important that the NHS stands up and recognises they have to do things that the general public understand, and not too simple, but it certainly shouldn't be too long.
Yeah, absolutely. And, my background is health comms, having spent, almost 30 years now in health and social care. So I'm going to defend them a little bit from that perspective. However, I will say that the communications, the specialty and the function that it is, it's because it is that executive function of strategic communications. They are often missing from those conversations, ironically, when it comes to the teams that are responsible for communicating directly with patients. So the messages that go from GP practices into the NHS app or into whatever portals, no comms professional has ever seen that. They don't get involved in those conversations. The leaflets that go out around, this is how you explain diseases, not comms related. So that is kind of one of the elements that we need to kind of talk about and pick up as a system. Is actually just because we live in this health and social care bubble and we all understand the acronyms and we all understand the shortcuts, that's not the world that everybody else lives in. And we need to be really mindful of that.
Doing something, Angus, and you may not believe it. 2023, summer. I'm thinking about starting to produce health AI webinars. I don't know that much about the subject. I spent a few days researching. I said, oh, here's an individual who seems to know what he's talking about. I did a cheeky thing. I used my marketing magic to get his mobile phone number, and I cold called him. And he was very gracious. He gave me a lot of excellent advice and guidance. Set me on my journey. Suhail Chugtai. I like those full circle moments. And we're going to start the after party soon. If you're on LinkedIn Live, you'll see like these Zoom blocks in the comments. Just click on one of them and you'll join us in here. And if you're in the audience on Zoom, if you want to speak, you have a question, you can put it in the chat, but you can also just raise your hand and I'll invite you on. I can either invite you onto the panel or allow you to speak. And thanks, Dr. Collins. I'm going to bring you on in a few minutes. Just before we end the event, the LinkedIn Live, Miller, did you want to give a final word?
Yeah, I mean, today is an amazing day. I mean, I learn a lot, especially on a very general context. So I'm the only one from the global south. So in the NHS context and FDA context in the global aspect, the developed nation. So now we're talking about a point. That's the only difference what I see from a different continent perspective. So the environment, which is talking about how we accept AI and whether we're going to keep the leash and at what point. So that's the discussion. And still, there's a huge global south aspect also allowed to have somebody talking about that in the after party also. So still we are looking for this dog itself. So that's something we have to discuss further. The data, which is the main source for the AI to learn and make the right decision, even considering empathy towards human. But this part of the world, roughly around 4 billion people's data, it's not yet in the loop to learn. So it's only in a silo. It's only become general if we have the entire world into one place. So we have to learn parallelly and we have to unleash certain things in different part of the world. So pleasure to be here and looking forward for the after party. Thanks.